You may start your session.
Good afternoon, doctors. Welcome to you. Welcome to this webinar on influenza and its prevention. Today we have got two eminent speakers, Dr. Ravindra Chopra and Dr. Ketan Shah with us. Welcome, doctors, for this presentation. Now, this presentation is sponsored by Heathrow Healthcare. Heathrow Healthcare, as we all know, the journey began in 1993 with 30 years of excellence and 36 state-of-art manufacturing facilities. We have got 300 plus production portfolio with presence in 126 countries, 21,000 employees globally, and amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Heathrow Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers with wide range of products encompassing multiple specialties, pioneering in quality and innovation. And we have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antiviral, offered fluir, the oseltamivir, favipiravir, and remdesivir to the patients, for which in August 2020, we received an award of Pharma Excellence for COVID drugs, which was given to Heathrow Healthcare. Today's webinar on influenza and its prevention, as I said, we have got Dr. Ketan Shah with us and Dr. Ravindra Chopra. Dr. Ravindra Chopra is MBBS MD Chief Pediatrician and Director, Muskan Hospital, Surat. Dr. Ketan Shah is President, Surat Pediatric Association, National Trainer, ATM, PSPP, ASK, IAP, CPIDC, How Do I Investigate, National Antibiotic Practice, National TB Module, and Rapid Module, National Secretary, Pediatric Rheumatology Chapter, 2005-2006, Organizing Chairperson, National Rheumatology Meet, 2006, EC Member, Gujarat Pediatric Association, 2014-2019, EC Member, ID Chapter, 2013. With this, I hand over the session to Dr. Ketan Shah for further deliberations. Sir, over to you.
Yes. Good afternoon, everybody. Thanks to the Heathrow Healthcare, Samriddhi and Dr. Prashant for giving us this opportunity. To all my colleagues, this talk is basically flu, which is going on nowadays. Every year we get a lot of flu patients, how to manage them, and what is the important role of oseltamivir in flu management. My co-colleague, Dr. Ravi, which he has been introduced by Dr. Prashant. He's an eminent pediatrician from Surat, and he's keenly interested in infectious disease also. The content would be healthcare challenges in monsoon and their diagnosis, influenza and its complication, clinical evidence of oseltamivir, and guidelines for empirically use of oseltamivir. The healthcare related challenges in monsoon, we all know that it is an influenza-like illness, where not only influenza, but all other viruses, maybe respiratory syncytial virus, rhinovirus, nova virus, etc., they causes a lot of sneeze and coughing. H1N1 is our classical influenza. There is a severe acute respiratory illness called as a SARI, where exact etiology may not be established, but patient would have a lot of trouble in respiratory system. COVID-19 is one of them. We are very well conversant nowadays with COVID-19. There are few new variant also, but fortunately, the serious morbidity and mortality is not seen this year with COVID virus. India has a lot of flu disease. We would like to ask Dr. Ravi about these few questions Dr. Ravi, what we know about influenza in India, which season does it come, and what is the correct time to vaccinate? Over to you, Dr. Ravi.
Thank you, Dr. Ketan, and thank you, Hetero team, for inviting me to interact with stalwart like Dr. Ketan. Uh, if you talk about flu, first of all, we have to know what is influenza or influenza-like illness. So, in each and every case which present to us with flu-like symptom, it is not possible for us to diagnose influenza. So, a term is coined as ILI or influenza-like illness. So during the influenza season or whatever, if we have any febrile illness with respiratory symptoms, we with fever more than 100.4, we coin it as a influenza-like illness if it is associated with other minor symptoms like body ache, headache, and sometimes diarrhea. So this is a broad term. We coin it as influenza-like illness, and which is very common in our day-to-day practice in our OPD. And we live in Gujarat, which is in the southern hemisphere of our country. So we have our influenza peak during the monsoon month and post monsoon season. So it starts at the beginning of the monsoon and keeps on progressing and gradually progresses to the post monsoon season. Whereas in the northern hemisphere or northern part of the India, the peak is generally in the months of winter. So when the winter starts, the winter flu starts and it peaks during the peak winter season. So in India, if we see this chart, we can see that there are various peaks, but the most important peak is during the month of Feb and March, and then again in the July, August, and September. And hence, rightly, we have two kinds of vaccine, which is Southern Hemisphere strain and Northern Hemisphere strain, which may differ with minor variation or sometimes it may be the same. But because the virus keeps on changing, we have two kinds of vaccine, and the right time to give vaccine in our scenario is generally a pre-monsoon season. So generally, the vaccine is available to us in the month of April, generally around the end of the March or April, and we can inoculate to all our eligible patient at this time. Whereas the northern hemisphere vaccine is available after the month of maybe around September, October, and inoculated just before the winter season, maybe in September or October. Over to you, Dr. Ketan.
Thank you, Dr. Ravi. This graph is taken from Purple Book of Indian Academy of Pediatrics, which is basically a vaccine book, and we all follow the national guidelines written in this Purple Book. And Dr. Ravi has rightly said, we get two peak. These are the incidents or the case scenarios of influenza in India, which is around 2017. And the burden is too high globally also and in India also. These are the case reports from India. In 2022, 12,800 cases were reported and 399 deaths were reported. The mortality is also very high and the morbidity is also very high. The number are increasing day by day, and maybe currently in last 10 days, every pediatrician and every physician is seeing lot of influenza cases which needs pure attention. We'll be sharing a few case reports or the case history in subsequent slides. Indian data, we do have a confirmed data of influenza. There are more than 10 per 100 children who suffer from influenza. The incidence is very high. We had a pandemic in 2019 and in 2015 also there were 1809 deaths till March. These are the statistical data published in majority of the journal and by the government of India also. And Dr. Ravi has rightly said, we get two peak. One is in the January, February, and another is in October, July to September. This is an overview of influenza in India. The chart also shows that we have a significant number of cases which are increasing day by day. This graph is up to 2019, where the incidence is gradually increasing from 2015. The dynamics of the occurrence of influenza in relation to seasonal variation in Chennai, this was a 7-year cumulative study. Dr. Ravi, would you like to say something on this study? Over to you.
Yeah, thank you, Dr. So this study was one of the pioneer study to, the clear the myth about influenza in India. Previously, we used to think that influenza is a Western disease and may not exist in India or not very common health problem in India. So this was a study done over a period of 7 years to evaluate about the influenza virus, and it was done at the Department of Virology in Chennai in the year 2019 at King's Institute of Preventive Medicine and Research, where 36,670 specimens were subjected to influenza analysis. And it was basically progressed over a period of whooping 7 years. So the inference of this study was that influenza positivity that it started with the onset of monsoon season and it peaks during the post monsoon season. As we know that in this study was probably done at the southern hemisphere, southern part of the country, and rightly so, as we conclude in our statement also that positivity will more be in monsoon and post monsoon season. Next, please.
Thank you, Dr.
So,
Ravi.
yeah.
Please go ahead.
Yeah, so what is influenza? So influenza is one of the most common infectious disease, and it is, I think, one of the most infectious disease. So very fast spreading disease caused by influenza virus, which is a RNA virus, and it is a very highly contagious airborne disease that occurs in seasonal epidemics and manifests as an acute febrile respiratory illness. It is a very variable disease which can be very mild, just passing by mild cold to a very serious disease leading into severe acute respiratory distress syndrome. And there can be serious outcomes of flu infection, which can lead to hospitalization, lot of morbidity, and some mortality also. I would like to just share one thought about basically NCDC has also made a portal of all reported influenza cases from our country. So, though these cases will just be an index of iceberg, maybe the top of the iceberg, because very less reporting in our country, and those cases only which are tested virologically will be reported in this site. And there is a very good, robust reporting system, and which is updated every month till the year of 2025 May. So now whole country has reported around, say, around 3,000 cases, and there are around 13 deaths this year, whereas last year it was like 20,000 cases and maybe around 300, approximately 300 deaths. So this disease is very variable. Some year because of the drift or shift in the virus, the virulence of the virus increases and it causes more disease and more mortality. So there are three types of influenza virus which are prevalent in our society commonly, though there are four kind of viruses, but the type D virus generally don't infect human. It is a cattle virus. So prime concern is influenza A, B, and C. So these viruses are categorized on their nucleoprotein and into varieties like A virus, B virus, and C virus. So type A virus is the most frequent virus and one of the most serious virulent virus also. It causes frequent epidemics due to the minor antigenic variation. So there is always a drift and the new sort of virus or with the newer variation, the virus comes every time. And there are periodic epidemics and pandemics where it spreads to larger part of the world. Then influenza B virus. So one more thing about influenza A virus, it has two domains, H, the hemagglutinin and neuraminidase. So that's why it is categorized as either H and N. So it may be H1 to 18 and N may be 1 to 11. So there are different variations and combination, H1N1, H3N2 like this. And influenza 2 virus which mainly affect human but can also a bit affect animals like pigs, and it comes direct in basically circulate mainly in the human and causes local epidemics. And there are two variations of this virus, Victoria and Yamagata. So probably they are very stable kind of a variation and doesn't change much. Influenza C virus is a little uncommon virus. It affects human only and it is very stable virus, and generally there are no mutations in this virus. And it is generally a kind of a endemic virus or minor epidemics which are very, very mild. So currently circulating virus, as we see that now currently we are getting most of the cases as H1N1, and previously like few months back when there was like last winter, we had lot of cases when H3 and 2 also. And like briefly, if we talk about drift and shift, as we already discussed, so drift is a minor antigenic variation which impart escapability of the virus to fool our immune system. And shift is a major antigenic change where probably this virus behaves as a new virus and it can spread very fast because of very low immunity to current generation. Over to you, Dr. Ketan.
Thank you, Dr. Ravi. This was just an introduction of what is influenza virus and how does it spread. The transmission of flu virus is very fast and very rapid, very close contact, maybe just a 6 feet away. Patient or person can get the infection. They spread by droplet made when people with flu cough, sneeze or talk. We, doctor, are always at the risk. They land in the mouths or nose of the people who are nearby or possibly be inhaled into the lungs. People should stay away from the affected person and stay home if sick. It is also important to have a hand hygiene, washing of the hand before you put your hand into the eyes, nose, or into the mouth. And the healthy adult may be able to infect other people from day one or even before the symptoms comes and up to 5 to 7 days after becoming the sick. Children may pass the virus for a longer time, maybe more than 7 days. So especially we get the patient, parents are saying कि उसके बाजू वाले बच्चे को भी सर्दी खांसी था and he caught the infection from these. So daycare center, school, auto rickshaw, car and the bus which takes a lot of children for the school, they are always at the risk of the disease. Uh, these are some differential diagnosis which has some clinical implication. ILI is influenza-like illness, H1N1, SARI, and COVID-19. Dr. Ravi, briefly, can you differentiate what are the differences between ILI, H1N1, SARI, and COVID-19? Over to you, Ravi.
Yeah, so ILI is a broad term basically. It includes almost everything. So it's a kind of a syndromic thing which may include H1N1, SARI, and COVID-19 also. It's a broader term. So as I already elaborated that ILI is characterized by fever, myalgia, cough, lethargy, and sore throat. So it may be very mild, so it may not have breathlessness. It generally has no loss of smell or taste, very less likely to have diarrhea and any other associated major symptoms. Whereas H1N1 generally is profound fever, myalgia, cough, lack of energy, sore throat, and it may progress into respiratory distress as well. But generally, there is no loss of smell and taste. There may not be diarrhea, but in few of the cases we have seen diarrhea also, and there are generally episodes of profound headache. Whereas SARI is a kind of a severe disease where the breathlessness is a hallmark of the disease. And COVID-19, we already faced this COVID-19. Primarily, there is a severe respiratory involvement, loss of smell and taste, and associated other systemic manifestations like diarrhea. So, by symptomatology, we cannot differentiate generally but it depends on seasonality, what virus is going on around, and uh, what kind of data we have in our day-to-day scenario. That can differentiate these viruses. Thank you.
Thank you, Dr. Ravi. As Dr. Ravi has rightly mentioned, you can differentiate these four entities, but for clinical purpose, like loss of smell and loss of taste, could be COVID, and diarrhea may be present in H1N1 and COVID also. So clinically difficult to differentiate. Just keep a watch on breathlessness, which is very important. The warning signs of flu sickness has been mentioned in this slide. Practically any child or any adult who comes with respiratory cardio compromise or CNS compromise, these are the warning signs. Any child having a respiratory distress, severe coughing, excessive crying, not able to feed properly, there is a cyanosis, there is a significant tachycardia, hypotension, and CNS wise maybe irritability or a very dull child not able to walk, getting very lethargy, child may be having a rash, decreased urine output. These all are the warning signs of a flu-like illness. These are common with other systems also. But as per our pediatric advanced life support charting, we might need to mention what is a pulse, BP, everything. Anything compromised with respiratory symptomatology are the warning signs. Same way in the adult also, including these all cardiac, respiratory, CNS. There might be CNS confusion, maybe persistent vomiting, lethargy, etc. So be watchful about the warning signs of flu sickness. Once you recognize the case as probably a respiratory tract with a seriousness, we need to have an etiological diagnosis. Dr. Ravi, can you highlight how you can diagnose flu disease by blood, by throat swab, by routine blood component? Over to you.
Yes, so diagnostic test generally can be divided into four categories. One is antigen detection test. Antigen can be detected in the secretions and the blood also, but it has a very poor sensitivity and very poor specificity. So it is generally an outdated test. Then comes the most important test is a PCR test. So there are two kinds of PCR, non-specific PCR and specific PCR. So specific PCR is the most certified test. It is pre-qualified by WHO. So generally we use a RT-PCR test to diagnose influenza. And it tells about the influenza A, B, or C, as well as it indicates about the type of the influenza virus, whether it is H1N1, H3, and 2, etc. Then there can be a retrospective diagnosis sometime by rising antibody titer to the influenza virus. And for research purpose, a viral culture can also be sent, which is just a theoretical test because it takes quite a lot of time, maybe more than 7 days. And for diagnostic or for therapeutic purpose, generally it is a useless kind of test. Coming to the complications, we have already, discussed about, Dr. Ketan has already elaborated the complications of the virus, influenza disease. The most common complication being the ARDS or lower respiratory distress, which is very common in our pediatric patient. Then in pediatric patient, other systemic complications like hypotension, myocarditis, muscle involvement, other respiratory site secondary infections like secondary pneumonia, sinusitis, otitis media, and worsening of any other chronic condition if the child is having, like any cardiac disease, renal disease, CKD, nephrotic syndrome. So these are the common complication we encounter in day-to-day practice. And if the child is having other neurological disorder also, it can be worsening of that particular disease. So, Dr. Kirtan, you are mute.
Yeah. Thank you, Dr.
Yeah.
Ravi. You nicely elaborated everything about diagnosis and complication. Let us move ahead with the few more important points. Management of influenza. We know that these are the respiratory viral disease. The basic management lies on a supportive treatment where you give a good hydration, round the clock, antipyretic medications, anti-vomiting medications, maintaining the good hydration oxygen level. But definitely there is a role of oseltamivir in management of influenza. The influenza can be very well managed with oseltamivir. Generally, we divide the cases into A, B, or C category. This is a rough arbitrary uh, distribution. A category is a very mild disease where you have upper respiratory sign symptoms. There you don't need any medication except a supportive. B is a little bit severe where you have a myalgia, cough, cold, a little bit lethargy. There you ask them to have a follow-up on the next, second, third day, and probably they are the candidate for oseltamivir.
Sir,
C is
can you resume
obvious.
slideshow? Your slideshow is not getting in.
Not there.
No.
1 second. Is it visible now?
Dr. K, please maximize the slides. So go to the slideshow
Yeah.
and from that to current slide.
Uh, 1 second. Huh? I think the message comes that your screen sharing is paused.
No, it is the screen is still shared, but
Are
screen
you
is visible,
okay? Are you able
but
to
it
see
is
the
not in a
slide?
slideshow mode.
Yeah, we are able to see, but not in the slideshow model. And we are able to see slide number 3.
Is it so? I'll again.
Just
Sorry.
Yeah,
yeah.
yeah.
Now, are you able to see the slide treatment with antiviral drugs?
No.
Actually,
Okay.
we are able to see only content slide. The slide number 3.
Something went wrong. 1 second.
Maybe
I'm
you can
again.
stop sharing. You can stop sharing and again start sharing.
Yeah. Yeah.
Otherwise, I will start.
Now, are you able to see the slide number?
Yes, 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 yes.
Yes. Yes.
Now we are able to see, but make it a slide this thing.
Are you able to see now?
Yes.
Okay.
No, it is
So,
not in a slideshow mode. You have to go to slideshow and from current slide you can, continue. It is in minimized mode.
is it so?
Yeah.
No, I have made it a slideshow.
Yeah,
Yes.
yeah, yeah.
Yes.
It's okay
Now.
now. Perfect, perfect.
So we were just discussing about the treatment of influenza disease. Category A is a very mild disease. B is an intermediate zone where you can have a follow-up on second, third day, and then you can start treating them with oseltamivir. And category C, obviously, the all red flag signs which we discussed out. There, or day one, you can start the oseltamivir without any confirmation of diagnosis. We'll affirm these decisions by subsequent slides and presentation. Treatment with antiviral drugs for influenza, we have a neuroaminidase inhibitors. They block the viral neuroaminidase enzyme, which is critical in releasing viron from the infected host cell. So virons are released from the host cells. If you can block this by the drugs like oseltamivir and zenamavir. Oseltamivir is a very well studied drug, then zenamavir. The another is adamantinase, which is M2 ion channel blocker. They interfere with hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cells. Active only against influenza A virus, while the neuraminidase inhibitor are active against A and B. So these group of drug, amantadine and remanatidine, has a very limited role and they are not as much effective as oseltamivir. Oseltamivir is a patent and selective inhibitor of the neuraminidase enzyme. It is a prodrug which is converted to the active form in the liver, and it inhibits influenza virus replication and pathogenicity. It prevents further spread of the infection. It is effective against all strains of A and B virus, which is a very important highlighting point. This photograph shows how does the oseltamivir works. These viron, which is there, the neuraminidase inhibitors are here. The drug can block this, so there is no release of virons. Thus how the disease can be controlled. It was the first oral drug neuraminidase inhibitor which was approved by more than 100 countries, including CDC, FDA, and American Academy of Pediatrics. These are the dosage recommendation. Adult, it is 75 milligram BD dose. Children, according to the weight, either it is a 60 milligram per day in 2 divided doses. 15 to 23 kg, it is 3.75 ml. 23 to 40 kg, 5 ml, and more than 40 kg, 6.25 ml BD dose. It is to be given for prophylaxis also when you are in contact with the flu disease patient. The dosage is once a day, as mentioned in the chart, 30, 45, 60 to 75 milligram. In infant, below 2 weeks to less than below 2 weeks, it is not recommended, but 2 weeks to less than 1 year of the age, 3 milligram per kg twice a day can be given. Dr. Ravi, let us have some real life case scenario discussion. I hand over to you. Please elaborate the cases and how does the oseltamivir has worked. Over to you.
Yeah, thank you. So these are the real case scenarios which I encountered during my practice in the last influenza season. So there are three kinds of cases that we are, uh, discussing here. The first one is a Ishani. She was a 6.5-year-old female child, resident of Surat, Vesu. The child was immunized for routine childhood vaccination. She presented with fever high grade 103, 104, which was almost persistent throughout the day and was not responding very well to oral paracetamol. It was also associated with cough and cold for the last 2 days, throat pain, which was increasing in severity since last few hours, and child also started having breathlessness. There was no significant past or family history in this case. So when we received this child, she was 17 kg, well built, good height, 117 centimeter, around 50 centile. Child was well nourished. She was highly febrile with a oral temperature of 104 degree Fahrenheit, with mild tachypnea and a respiratory rate of 42 per minute, with mild subcostal retractions, tachycardia with a heart rate of 150 per minute, and blood pressure was appropriate for the age. Child was having a saturation of 93 to 94% on room air at the time of admission. Throat was severely congested with watery nasal discharge, and child was having bilateral fine crepitations, and rest of the systemic examination was normal. So we proceeded to stabilize the child in emergency, started on supportive management and oxygen, and investigated the child. She was having a hemoglobin of 11.9 with a almost normal count, with a near normal CRP. Later on, after stabilization, we did a chest X-ray. Unfortunately, I don't have the X-ray film, but the chest X-ray was showing uh, kind of a perihilar opacity, kind of reticular perihilar opacities, and very prominent bronchovascular marking. But there was no patchy pneumonitis or any lobar pathology. Considering above finding and a sick child, a respiratory multiplex panel was sent for the child, and which was later positive for H1N1. Next. So as I already narrated, the child was started on IV fluid, oxygen inhalation, and nasal cannula at around 3 to 4 liters per minute. Child initially was managed with paracetamol and IV fluid, and on admission, child was started on IV antibiotics also. But on getting H1N1 report positive, oral oseltamivir was added and further continued. So child continued to have high grade fever for the next 24 hours and required uh, almost intermittent paracetamol infusion. But after 24 hours, fever spikes started to decline, respiratory distress started settling, and around 32 hours, child was weaned off from oxygen. At around 72 hours, child was afebrile with no respiratory distress, but the cough persisted. And later, the child was discharged on oral oseltamivir and some decongestant for the and cough suppressant for the symptomatic relief. So this was a highlight of rapid progression. Like in a around few hours, the child progressed from simple mild cold and coryza to kind of a significant respiratory distress. And with the timely management and supportive treatment plus the initiation of oseltamivir, child recovered dramatically over a period of just around 24 to 48 hours. Next, please, Dr. Ketan. So
Uh,
this was another case. This is a Prishit, a 10-year male child. He was a known case of seizure disorder, and a child was on oral valparin. Child used to have some breakthrough seasons in between, but did not have any episode in the last around 6 to 7 months. This child presented with persistent cough for 3 days. Initiation was generally the complaint was cough, and then fever started on the second day of the illness, which was around moderate to high grade 102 and 103, with severe weakness, body ache, and heaviness in the chest. And then finally, child presented with one episode of stiffness of the both upper limb and uprolling of the eyes, which was very transient. It was associated with main complaint with the child was heaviness of the chest. On examination, child was when admitted in emergency. Child was 33 kg, 137 centimeter height, temperature 101, oral temperature with pulse of 137, respiratory rate mild tachypnea 38 per minute, maybe because of fever and little bit of respiratory compromise, as with maintaining a good oxygenation under room air with a fairly normal BP. There was no respiratory distress. Child was fully conscious, oriented with no abnormal movement on admission. Throat was grossly congested. Child had bilateral conducted sound with lot of rhonchi. Other systemic examination as well as CNS examination was normal. The child started with routine investigation, hemogram and CRP, more or less normal. X-ray had the bilateral perihilar prominence. A flu panel was sent because it was a flu season at that time. We got a lot of flu cases during this period, and it was suggestive of influenza B.
Dr. Ravi, I have added these X-ray, which is last year's patient. The same description which you had said. There is a
Yeah,
perihilar
Dr. Ketan.
prominence and
Yeah,
reticular
it very
pattern.
much resembles the X-ray of our child. So I could say probably it very much matches our child's X-ray.
Yes,
Thank
yes.
you for that.
Yeah, sure. Huh?
Yeah,
So this is a classical X-ray to the viewers for influenza perihilar interstitial involvement. Over to you, Dr. Ravi.
yeah. So on admission, child was started on IV fluid, IV amoxiclav. The child was already on oral amoxiclav from some general practitioner. So we continued IV amoxiclav with levosalbutamol nebulization. And after getting this influenza B report, we added oral uh, Fluvir, and there was a dramatic improvement after with the supportive treatment and oral oseltamivir. Child improved within 24 hours, nausea, lethargy, They were the minor symptom which persisted, and rest of the symptom improved drastically. Child became very alert, agile, and very comfortable, and was discharged on day third of the illness with oral oseltamivir and supportive treatment. So, message here is that any kind of a illness or any kind of a chronic illness might be complicated by the flu, or flu might complicate the illness. So that's how we intervened and investigated and started the appropriate therapy, and child had a wonderful improvement.
I think even I would like to add, Dr. Ravi, you rightly
Yes.
mentioned that any morbid patient or any child having some disease, influenza and the given disease can interact, and both the disease can flare up. Like in your case, epilepsy has been flared up, sometimes nephrotic syndrome, sometimes asthma can also flare up with influenza. So comorbid condition is a absolute indication to start oseltamivir even in the category B of the cases. Now,
Yes.
case 3, Dr. Ravi, over to you.
So this was a teenage girl, 14-year female child. She presented with fever for 6 days. So initial 2 days it was high fever. So child was traveling somewhere. She was not in Surat. She had been with the parents to some village, maybe their native place. So there they noticed a fever and initially started paracetamol. Fever gradually subsided in 2 days. When the child reached to Surat, the fever has already almost declined in severity, and it used to come around 8 to 12 hour, and generally not exceeding 101. There was increasing cough. So cough started initially, but it was increasing. But the main presenting symptom was severe lethargy, even unable to stand, dizziness, and very poor appetite in the child. There was family history of fever there. When they where they traveled, the family had uh, cases of cough and coryza in two of the family members. So when we examined the child, child was very dull looking. Hence, the child was admitted at that time. Child was febrile with a temperature of 101 degree Fahrenheit. Child was quite dehydrated because probably child was not drinking anything and very poor appetite. Blood pressure was on the lower side, 90 by 60. Mild tachypnea with respiratory rate of 32 per minute. Saturation on room air was sorry 98%. With mild tachycardia 146 per minute. But there was no respiratory distress, no retractions, no grunting. Throat was congested, conjunctiva was congested, stomatitis was present, and there were fine rails all over the chest. Rest of the systemic examination was totally unremarkable. So we started with initial investigation.
These are the
Hemoglobin was
investigations.
14. Hello?
Yeah, Dr. Ravi.
Yeah. So child was probably a little dehydrated, so little hemo concentration, little bit of leukopenia, and platelet counts were also little bit on the lower side. CRP was normal, and when we got the X-ray, there were bilateral lower zone haziness. So it was a parahilar prominence, parahilar opacity, plus more on the lower zones. And considering what it was, because it was not falling into any particular thing, we initiated a biofire panel which was positive only for influenza A virus H1N1. So then child was initially started on IV fluid, IV ceftriaxone, nebulization, and then after getting H1N1 report, we added on oral fluid. Though it was quite late in the illness, around 6, 7 days, but still because it was a positive influenza and we didn't have much, so we started oral oseltamivir. After rehydration, child showed significant improvement in GC, but respiratory symptom continued to persist, and we continued oseltamivir and supportive management. And in around 36 hours of oseltamivir therapy, child improved dramatically with improvement in the fever, respiratory sign, and general well-being. Appetite also improved dramatically. and the child was discharged after 3 days of oral medication. So here the message is that it may be late in the illness, but sometime we can try oseltamivir. It can be effective even in the later phases of disease, which we see in this case.
Thank you, Dr. Ravi. Very nicely elaborated case scenarios where the effectiveness and the role of oseltamivir from day one to even in a later stage also. If you add oseltamivir, the recovery is very fast. Same way, the infant who is 2 weeks old, who had a history of fever, cough, cold, and a family history of cough, cold, and fever. One adult was admitted for respiratory infection. Here also the line of action remains same. We need to start with oseltamivir, maybe empirically looking to the scenario or the epidemiology of the city. Same way, a known case of nephrotic syndrome, who is on steroid, who is not vaccinated, even for the routine vaccination, he is the right candidate to start the oseltamivir whenever he get the respiratory tract infection, especially in these August-September month. Same way, a 9 years old, a known case of asthma coming with fever, cough, and running nose. We all know that the influenza can increase the coughing episodes, can have a prolonged illness also. So asthma will be triggered off, the episodes of coughing will increase. Here also there is a role of oseltamivir. We should start even with category B. So this is a wonderful drug for walking pneumonia and early onset severe symptoms. Oseltamivir should be prescribed. There are benefits of empirical and early use of oseltamivir. There are thousands of clinical trials which has mentioned that once you diagnose influenza-like illness, the chances of antibiotic use reduced by 26%. Influenza-related lower respiratory tract complications resulting in antibiotic therapy also reduces by 55%. Hospitalization ratio also increases to 59%. This has been done and the data are collected from 3,564 subjects. So reducing occurrence and severity of pneumonia due to H1N1 by early oseltamivir administration. This was one more study of 442 patients. Median time from symptom onset to drug administration was 5 days. Subjects were divided into 4 groups based on time of drug starting, less than 2 days, 3 to 7 days, 8 to 14, and more than 14 days. In majority of the cases, the seriousness or the development of pneumonia was significantly less once the drug was started earlier. Even in the later days also, if you start the drug, the chances of getting pneumonia was significantly less. The second thing, there were early discharge, though those patients who were on the oseltamivir. This is the same slide mentioning that the discharge of the patient was quite earlier if the drug was started earlier. So the recommended, now we just mentioned about the post-exposure prophylaxis. Whenever you are exposed, the 10 days course of prophylaxis is recommended. Doses we have already discussed out. And if there is an epidemic in the society up to 6 weeks or even up to 12 weeks, it can be recommended. It's a once a day dose and it has no side effect which warrants its use. So guideline recommendation from majority of the authorities, WHO do recommend that empirical treatment is strongly recommended. It should be started as soon as possible. Laboratory confirmation may not be necessary for the initiation of treatment. Negative test does not exclude the diagnosis. If high-risk individuals have been exposed to a patient with influenza, presumptive treatment is recommended. Once again, from Ministry of Health and Family Welfare, Government of India, same recommendation is there for even a severe respiratory infection. Empirical treatment with oseltamivir is recommended. In adults with CAP, community-acquired pneumonia, who test positive for influenza, the treatment regime includes antiviral with antibiotic, and there also the risk of getting seriousness significantly decreases. This is a recommendation from American Thoracic Society. So in summary, proper diagnosis can and early treatment can prevent flu complications, which has been very well narrated by Dr. Ravi in his case scenario with WHO and a Government of India recommendation. Empirical use of oseltamivir reduces lower respiratory tract complications, hospitalization, and antibiotic use. WHO, American Thoracic Society, and Government of India do recommend empirical use of oseltamivir. Thank you, everybody. I'm really thankful to the hetero with Dr. Ravi and Dr. Prashant and Samriddhi and the ground staff for giving us this opportunity.
Thank you, Dr. Shah. Thank you, Ravi. Sir, if you can stop your presentation, the few questions
Yes.
I will.
Yeah. Yes, sir.
Yes. So, do you think the incidence of viral infection has increased and possibly at the cost of bacterial infections?
Dr. Ravi, can I answer that?
Yes, yes, please.
The viral infection has a seasonal variability. The environmental factor do affect. Like in the summer, we were not having any viral infection, but once the rainy season started, the humidity, overcrowding, schooling, everything significantly increases the viral infection incidence. So these are the reasons why the viral infection has increased.
So,
Over to you.
usually, sir.
Yeah,
Yes.
Dr. Ravi.
Yes, sir. Dr.
I
Ravi.
think the incidence of infection remains almost more or less the same, but with improved teaching and improved antibiotic awareness and stopping of antibiotic abuse, we are more and more looking into viral infections now,
Okay,
and we are
okay.
diagnosing it more. Like few years back, if you ask me, would you diagnose influenza? I wouldn't have anything to diagnose, wouldn't have anything
Correct.
to prove. Now I have the confidence. I can go for influenza test. I can absolutely stop the antibiotic. I may not give any antibiotic, or if
Absolutely. That's
ever
what
it
we are.
started, I can stop it.
And
So
possibly
I won't label it as a pneumonia in general. It is bacterial
correct.
pneumonia. Rather, it is an influenza. So
Influenza.
this impact has been there with improved teaching, I think, with
Yes.
teachers like Dr. Ketan and other seniors.
Hmm.
And possibly, possibly post-COVID awareness, health awareness has also increased, I suppose.
Yes,
Yes.
yes.
Generally, how soon the child is brought to pediatrics? Of course, the cases have shown that sometimes the child is brought as late as in after 4 5 minutes. But generally, on an average, how soon the child is brought to pediatricians in our country?
Uh,
Because first line to GP होता है.
no, nowadays, sir, below 1 year child or even below
Yes,
2 years, parents are very much concerned. So even
rightly
with
so.
minor cough cold, they come to us. And when they come to us on day one, we evaluate as per A, B, C. And at
Right.
present, it is an high epidemic. So we instruct them that if after 2 days your child is not well, coughing very badly, or deterioration of symptoms, we request you to come back again on day 3. If the symptoms are worsening, I have started oseltamivir empirically. Now, sir, almost not to the hetero, but in general, in the
Right, that's
OPD,
right, that's right.
almost
Yes.
15-20 patients, we are starting oseltamivir,
It's
looking to
wonderful.
the high risk category. Now I have a 6-7 patients who are influenza-like illness. They are not affordable, so I have not done the PCR test.
That's right.
But
Yes,
a
yes.
lethargy, which we had seen one adolescent admitted today morning at 4 o'clock with 5 days history, fever, flush, coughing, eyes congested, dengue virus negative, and coughing is there. So these all are influenza disease.
Yes, and clinical, finally, you have the clinical feel that this patient is a viral infection.
Yes, sir. Yes.
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 Should oseltamivir be started empirically or after investigations?
Dr. Ravi, over to you, please.
Yeah. So most of the cases, it is empirical treatment.
Empirical treatment.
Like when most of the time the patient falls in category B, like if the child has a very high grade fever, or he has some coexisting illness, or he is a very young child, like less than 5 years, with respiratory symptoms. So I would like to say one thing here, add one thing. Like when I started my practice, it was an era of antibiotic. So
Correct.
everybody has a respiratory infection, antibiotic.
Correct.
So then came the era of allergies, which is still continuing. So many of the patients who come with respiratory symptom without fever, or maybe mild fever, allergic rhinitis, or maybe some asthma. And now, with more and more knowledge of viral etiology, now as Dr. Ketan has already said, that many of the
Correct.
patients we are starting empirical fluvial. Like
Oseltamivir. Yeah,
in
yeah.
many of the cases, oseltamivir is started empirically, which falls in category B, and if they are hospitalized, definitely in category C also. Like we start oseltamivir, send the sample, because category C we generally send the sample. But in case if we are not able to send because of cost constraint,
Yes.
then also we start oseltamivir.
Oseltamivir. So how soon the report comes after you send the sample?
I think, sir, within a
So
day.
In a
yes,
day.
within few hours, like
Few hours, yeah.
depending on which kind of investigation you send, you will get report around 6 hours at the
6
max.
hours.
Our test running time is at 3 o'clock in the afternoon. So by 5 o'clock, we get the report. If you send
Wonderful.
the sample at 7 or 8 o'clock in the night, maybe next day evening you get the
Next
report.
day.
That's right.
Yes, yes,
That's right.
yes.
That's right. That's right. What are the factors on which clinical effect of oseltamivir depends? Sometimes there may not be a good response to oseltamivir. Very possible है.
Uh, Sir, the poor response, first thing is patient is not tolerated medicine properly. We often get there is some bitterness in the
Yes, yes, yes,
molecule,
yes, yes,
so they
yes.
throw out. I have a one patient who has been admitted and not ready to accept the oseltamivir. So repeatedly we are mixing it with something. So
Correct.
poor tolerance is one. The comorbid condition is a second
Oh,
factor
yes.
which gives a poor response. And third, the severity of the disease. Once it has progressed very badly with respiratory or system compromise, then probably the result
The
won't
response.
be that much effective. Maybe we were late in starting oseltamivir in these cases.
Yes.
Yes. It's quite likely
Most
that some
important is
patient.
generally it is not recognized. They receive
That's
some
right.
antibiotics from general practitioner, or maybe
Yes, yes.
our colleagues also. Sometimes we recognize it late and then start oseltamivir. By that time, the respiratory illness has already settled in,
Sadly,
and
yeah.
that's why it responds slowly, or maybe
Only.
very poor response to the drug.
Generally, for how long you administer oseltamivir once you start?
So it is a 5 days recommendation.
5 days recommendation.
Yes. Beyond 5 days, it is not
It is not a
recommended.
necessary. Yes. And overall, your experience of oseltamivir, take-home message for people who are attending.
Uh, I think it has to be used. We need to follow the guidelines. Nothing from our side. We follow WHO guidelines, we follow IAP guidelines, we follow the epidemiology, and we look at the comorbid condition of the patient. So, experience is excellent, should be tried. The only thing important point is the safety profile of drug is wonderful. So, there is no side effect of oseltamivir in any system. So, it should be used. This is my message. Dr. Ravi?
Yes, I think when you have the clinical scenario, when you have you use the proper guidelines, you categorize the patient, and you have the confidence of using oseltamivir, use it early. And I would say rational use. It should not be irrational use that
Correct,
each and
correct,
every
correct.
case you start using the drug.
Right.
Then probably it will also come under resistance.
Resistance.
But with proper guidelines, I think this is a wonderful drug.
Thank you, Dr. So those are lovely, wonderful insights. You have shared your clinical insights into different patients. Thank you so much for this presentations. Thanks, Dr. Ketan. Thanks, Dr. Ravi, for these wonderful presentations.
Thank you, sir.
Thank you, thank you, sir, marketing team Hitro. Thank you, IT team, and thanks all the field people for this super coordination. Thanks all of you, and wish you a very pleasant afternoon. Thank you.
Thank
बहुत
you,
अच्छा
sir.
हुआ sir. Thank you.
Thank you, sir.
Thank you. Bye bye. Bye.
Thank you, Samriddhi. Bye bye. Thank you so much.
Yes, sir. Good day.
Thank you.
Yes, sir. Yeah.
Okay. So we are leaving.
Thank you, whole Acro team.
Yes, sir. Yes, sir. Yes, sir. Thank you.